Welcome back, Focus Learners. Today we're diving into a massive, absolutely crucial topic for your NCLEX prep, nutrition and elimination. You already know clinical judgment scenarios are the name of the game, right? Well, this explainer is built to get you moving fast and thinking critically. We're going to break down the must-know labs, those highly specialized diets, and the essential safety alerts you will 100% see on exam day. So let's jump right in. Just to show you how huge this is, take a look at the 2026 NCLEX RN test plan data. If you check out the pharmacological and parenteral therapy section, nutrition and elimination topics, things like TPN, med interactions, and tube feeds, they actually make up 13 to 19% of that entire category. I mean, that is a massive chunk of the exam. The stakes are super high here, not just for passing the test, but, for keeping your future patients safe. To keep us from getting totally overwhelmed, here is our game plan. 1. Nutrition foundations and labs. 2. Therapeutic and clinical diets. 3. Tube feedings and TPN. 4. Food and medication interactions. And 5. Special high-risk diets. Having this roadmap in your head is going to help you lock all this info down. All right, starting off with Section 1, Nutrition Foundations and Labs. Before we can treat anybody or prescribe a diet, we really have to know exactly where they're starting from. Now, this right here is a classic NCLEX priority trap, so pay attention. We're looking at the two main protein labs, albumin and prealbumin. Here's your big alert. You have to keep these two firmly separated in your mind. Albumin has a super long half-life, right around 20 days, so it's slow to change. It is your chronic marker for malnutrition. But prealbumin, that one has a half-life of just 2 days. It's your acute short-term marker. So if you want to know if a patient's nutritional status has changed recently or if that tube feed you started 3 days ago is actually doing its job, you check the prealbumin. Moving on to vitamins and minerals, we've got two ridiculously catchy memory tricks for you. First up, orange juice equals iron's best friend. When you're giving iron for deficiency anemia, you always want to pair it with vitamin C to massively boost absorption. But keep it far away from calcium and dairy. Okay, second trick, stones, bones, groans, and moans. This is brilliant for remembering hypercalcemia. A patient with way too much calcium is going to have kidney stones, bone pain, abdominal groans, like cramping, and neurological moans, meaning confusion. Remember the rhyme and you'll nail the symptoms every time. Let's move right into Section 2, Therapeutic and Clinical Diets. We're shifting gears from baseline assessments to the actual specific dietary interventions you're going to manage and teach. So here's your standard post-op hospital diet progression. You start NPO, move to clear liquids, then full liquids, soft, and finally regular. Simple enough, right? But there are two huge takeaways here. First, clear liquids, stuff like water, broth, jello, those are strictly short-term. They're absolutely not nutritionally adequate for the long haul. Second, and this is a massive safety checkpoint, you must always assess for bowel sounds before advancing a post-op diet. If the gut hasn't woken up from surgery yet, putting food into it is just asking for a disaster. Okay, look at how the rules totally flip for renal patients. This is heavily tested. If your patient has chronic kidney disease, but they are not on dialysis, you have to restrict their protein. Why? To protect those kidneys from doing extra work. But the very second that patient hits end-stage renal disease and starts hemodialysis, the rules flip entirely. Dialysis literally pulls amino acids and protein right out of the blood. So a dialysis patient actually needs an increase in dietary protein to make up for what the machine is taking away. All right, Section 3, Tube feedings and TPN. We are raising the stakes here. When we bypass normal eating and go straight for tubes or IVs, these protocols aren't just suggestions anymore. They are absolute matters of life and death. Think about it. If you're dropping an NG tube, you're essentially flying blind down the patient's throat. How do you actually know you're in the stomach and not the lungs? Well, here is your non-negotiables step by step. First, you check. Second, you verify with an X-ray. And third, then you feed. You've got to know that the old school whoosh test, where you just listen for air over the stomach, is notoriously unreliable. It is totally unsafe on its own. An X-ray is the absolute gold standard before you push that first feed. No exceptions. Once that tube is in and verified, we have some rapid-fire safety rules. Aspiration is the #1 risk with tube feeds, period. So keeping the head of the bed elevated 30 to 45 degrees, non-negotiable. You also need to flush the tube with 30 ml of water before and after meds, and never, ever mix different medications together in the same cup. Oh, and here's a big myth buster for you. If the tube gets clogged, do not pour cranberry juice or soda down it. No way. You only clear a clog with warm water or, if the doctor prescribes it, pancreatic enzymes. Let's just pause for a second. Think about this. What happens when the gut just doesn't work at all? Like, what if a patient has a severe bowel obstruction or short bowel syndrome? The general rule in nursing is if the gut works, use it. So, what exactly is our plan when we literally cannot use it? The answer is total parenteral nutrition, or TPN. It's essentially liquid gold delivered straight into the bloodstream. And because it's going right into the blood, safety is everything. TPN is super concentrated, so it has to go into a central line only. It's also packed with sugar, which bacteria absolutely love, so you have to use strict aseptic technique to prevent a massive infection. It needs its own dedicated line. It does not share with other meds. And listen to this. You never speed up or slow down a TPN rate just to catch up. Doing that abruptly risks sending your patient into severe, sudden hypo or hyperglycemia. And speaking of severe shifts, we really have to talk about refeeding syndrome. This happens when a deeply malnourished patient suddenly gets aggressive nutrition, like TPN. The massive influx of glucose causes a huge release of insulin, which just drags potassium, phosphate, and magnesium rapidly out of the blood and into the cells. If you see a sudden phosphate crash along with muscle weakness and shallow breathing in a new TPN patient, that is a giant red flag. You need to immediately slow or stop the infusion and call the provider. Moving on to Section 4, Food and Medication Interactions. We're looking at the dangerous chemistry between what a patient eats and the meds they're taking. You're going to see a lot of clinical judgment questions on this. Let's break down these high-yield interactions, starting with warfarin. The biggest safety rule here isn't to totally eliminate vitamin K, which is in green leafy veggies, but to teach consistency. If they suddenly eat way more or way less greens, it will wildly destabilize their clotting times. Also, look at levodopa. Dietary protein actually decreases its absorption, so they need to take it on an empty stomach. Statins, absolutely zero grapefruit juice because it causes toxicity. And bisphosphonates have to be taken with a full glass of plain water only, and the patient has to stay upright afterwards so they don't get severe esophagitis. Now let's see how this ties into psychopharmacology. If your patient is taking an MAOI antidepressant, you have to warn them about the life-threatening risk of a hypertensive crisis if they eat tyramine. Tyramine is found in stuff like aged cheese, wine, beer, cured meats like salami, soy sauce, avocados, and bananas. Mixing any of those with an MAOI will cause a massive blood pressure spike, and they'll usually show up complaining of a pounding headache and a stiff neck. Honestly, memorizing that whole list can be kind of a pain. So the legendary Mark Klimek has this amazing memory trick. If it sounds delicious, an MAOI patient can't have it. I mean, think about it. Charcuterie boards, wine, fancy cheeses, cured meats. It's a perfect instant little mental shortcut for filtering out dangerous menu options on exam day. If it belongs at a fancy dinner party, just keep it far away from your MAOI patient. All right, our final section, number 5. Special high-risk diets. We're covering some complex conditions that require a massive, lifelong overhaul of how a person eats to prevent long-term damage. First up is dumping syndrome. This is a common issue after gastric surgery, and the physiology behind it is actually fascinating. Because part of the stomach is missing, food empties out way too fast. A dense hyperosmolar bolus of food, called chyme, just dumps straight into the small intestine. It acts exactly like a sponge, rapidly sucking fluid out of the bloodstream and into the bowel. This crazy fluid shift causes early symptoms like dizziness, sweating, and a racing heart. And then, a couple of hours later, they get a huge insulin spike from the rapid sugar absorption, leading to severe late-stage hypoglycemia. Because the fluid shift is so dramatic, our nursing interventions for dumping syndrome are very specific and honestly kind of counterintuitive. Our goal is to slow digestion way down. So we give small, frequent meals, high in protein and fat, but really low in simple sugars to avoid that insulin spike. And here's the weird part. You actually tell the patient to lie down right after eating. It lets gravity help slow down the emptying. Plus, they should never drink fluids with their meals, because liquids will literally just wash the food right down into the bowel even faster. Next, let's talk about celiac disease. You gotta know this isn't just a mild intolerance. It is a full-blown autoimmune reaction to gluten that physically destroys the intestinal villi, wrecking the gut's ability to absorb nutrients. When you're assessing these patients, watch for a very specific triad: chronic diarrhea, steatorrhea, which is that fatty, foul-smelling stool from malabsorption, and dermatitis herpetiformis, which is this intensely itchy, blistering skin rash. The only fix? A 100% strict, lifelong gluten-free diet. To help you remember these restrictions, I've got 2 final powerhouse mnemonics for you. For celiac, remember, brow is out. BROW. Barley, rye, oats, and wheat. Those are completely forbidden. And then, for patients with PKU, a metabolic disorder where they can't break down the amino acid phenylalanine, remember PKU equals please keep unsweetened. This is your reminder that they must strictly avoid aspartame. That's the artificial sweetener in diet sodas, and it's absolutely loaded with phenylalanine, which will build up to toxic levels in their brain. All right, as we wrap up this explainer, I want to leave you with one final incredible test-taking strategy right from the source material. When you're staring down a brutal clinical judgment question, the general rule is pick the most stable patient to leave alone or choose the least invasive intervention to do first. But what happens when literally every option on the screen is highly invasive and you have multiple patients crashing at the same time? That is where your deep clinical judgment gets put to the ultimate test. How will you prioritize then? Keep that in mind for your next study session, and I'll see you in the next explainer.